Well, hi, this is Brendan Bowman. I'm one of the nephrology faculty, and in this session, we're going to cover some basics of CRRT. I do some of the consultations in the ICU. The format can be somewhat confusing, and we'll try and cover the basics, some pitfalls, um, and some changes that we might make to deploying CRT in the setting of a COVID-19 surge. So here's the outline for this talk. Start with a fairly simple, straightforward case. Some basics about dialysis, problems with traditional dialysis that may suggest that CRRT may have a role, and why we might choose one modality over the other. What options are available, particularly in the time of a surge, where we may need to use multiple resources in addition to CRT and different kind of forms of renal replacement therapy. And then we'll dive into continuous therapies in general, the different flavors of CRRT, really, some common complications, practical considerations, including some changes and things to watch out for that we've learned from other providers in our specialty field, particular to patients with COVID, and then finish up with some summary points. All right, so here's the case. 65-year-old female with a history of coronary artery disease and COPD presenting from a nursing home with hypoxic respiratory failure. The patient was found hypotensive and had 2 days of abdominal pain and diarrhea preceding presentation to the ED. Family noted altered mental status on a FaceTime visit earlier, and this prompted a call to EMS rescue squad. In the emergency department, patient presents with AKI, a BUN of greater than 100, a creatinine greater than 4. The potassium, despite GI losses, is elevated, and lactic acid is approximately 5. And so we'll come back here and see that the patient is going to be admitted typically to the ICU service. The patients receive 3 liters of normal saline. The map improves, but the patient remains still hypotensive. The creatinine hasn't changed much, but the BUN's have been diluted down to 90. Patient's making some urine, but also has a non-gap acidosis, presumably from both the renal failure as well as the hyperchloremic resuscitation fluids and the previously noted gap acidosis. On admission to the ICU, the patient's intubated, noted to be tachypnic with increased work of breathing, and moved to one of the appropriate floors, one of the appropriate rooms on the 3rd floor. And COVID-19 testing comes back later that day and is positive. And I think this will, probably be a fairly typical case that may be escalated to the ICU in the coming days and weeks. So, questions that we ask, from the nephrology side is, what kind of things can we provide in terms of therapies? Why would we choose one over the other? Continuous modalities, as we said. How do we dose our renal replacement therapy? Meaning, how do we know what degree of dialysis to give? And there's a number of ways to kind of think through that. We'll talk a little bit about that in this talk. And what kind of troubleshooting problems can we maybe anticipate? So one of the first things before you dive into continuous therapies is to understand how, to be very simplistic about it, how blood is cleaned. How do we produce change in the solute concentration and remove that group of toxins we associate with uremia. And there's 2 fundamental concepts. Terminology here, I have kind of two ways to say the same thing here. Convection, or so-called convective clearance, is very similar to saying ultrafiltration, basically removing filtrate of blood, kind of skimming off the plasma water using a pressure gradient. And when we remove fluid, that tends to drag solutes across there. The other one would be classic high school chemistry concept of diffusion, which is just solute movement down concentration gradients, and in our case, across this permeable membrane. And those are the 2 major clearance techniques. And you can employ both of those in CRRT simultaneously or separately, and both will produce good effect. So this is just a cartoon, to show the rough idea around so-called convective or ultrafiltration clearance. And, basically in this situation, blood's coming in one side of this filter. And in a dialysis situation, we would have dialysate running counter current to that. and solutes would move down their concentration gradient. But in this situation, all we're actually doing is applying a pressure gradient down here, high pressure blood, low pressure in the remainder of the cartridge. And that filtrate of water and plasma that comes across these pores basically becomes your so-called ultrafiltrate. Another word for that would be effluent, but it's basically just um, plasma water. So nothing different than you would get if you popped a blister and had fluid coming out of that clear colored fluid. The electrolyte concentrations will be exactly the same in the ultrafiltrate because it is just a filtrate of the blood water down there too as well. So the potassium here will be the same as that in the blood. So in some ways you can think of this very crudely as dehydrating the blood. You're kind of concentrating the hemoglobin in some ways. One of the potential advantages of this modality of fluid removal is that it removes these middle molecules down here too as well. So as we pull fluid across this barrier, it will drag not only the small molecules, which are classic urea clearance that we talk about in regular hemodialysis, but it also pulls middle molecules through there. And these are protein-sized molecules, things like cytokines. And so there's some thought that that might be helpful in conditions like sepsis where you get cytokine storms and those things. And we'll come back to how that may or may not relate to COVID. But generally speaking, this is just ultrafiltration. And we'll talk about how you can actually use this technique. This isn't very much solute removal. Down here it's some, but you couple this with another technique of fluid replacement, CRRT, and that really leads to a kind of lower concentration of unwanted solutes in a method of CRRT called CVVHF, which we'll get to shortly. This is really the main clearance technique that's used in traditional hemodialysis. And you have about 500,000 people that are getting traditional in the clinic 3 times a week hemodialysis. And this is a little bit different in the sense that blood is still coming through at the same rate. A typical blood flow rate through a cartridge like this for a hemodialysis session might be anywhere from 300 to 500 mLs per minute. So a fairly brisk flow of blood. But counter current to that will be dialysate. And whatever is in high concentration in either of these two, and is different in the other medium of fluid, that will drive diffusion. And so this is so-called diffusive clearance. When we talk about clearance, we're talking about basically the ability to remove a solute from a volume of fluid. So in this sense, the dialysate that we're pumping into the cartridge has no urea in it, of course, when it goes in. And as the dialysate proceeds along this line and blood's coming in, the blood encounters the dialysate and urea will begin to diffuse down its concentration gradient. And so as the spent dialysate then goes out to the drain line and becomes effluent, it will leave saturated with urea. And generally that's by using this continuous flow of new dialysate, we prevent the dialysate from ever becoming fully saturated. And so we can continue and cycle that process. And so a typical 3 to 4 hour dialysis session can clean, generally the total body water of the patient reasonably well 3 times a week. Will prevent most of the side effects of end-stage renal disease. What you'll notice is that these middle molecules in pure diffusive clearance are not well represented. In this example, we don't really have much of a pressure difference here. What we're really using is simply the difference in concentrations of different substances to drive clearance of urea. Now, the same process happens in reverse. We have high bicarbonate levels in the dialysate, and that is taking advantage of its concentration gradient. So bicarbonate will diffuse in. If this patient had high potassium, we would choose to have a dialysate with lower potassium. That would drive diffusive clearance of potassium, but there are cases where we can raise potassium or raise calcium by using solutes in higher concentrations. Generally, this does a better job of small solute clearance than the previous convective or ultrafiltration clearance that we saw. So why would we even think about doing a continuous therapy when we know that we can do all the cleaning and fluid removal we need to do in 3 to 4 hours a day with hemodialysis? And generally, this comes down to hemodynamic stability and cardiac stunning. We know that hypotension to some degree occurs depending on the study you look at, in up to 50% of dialysis sessions. And obviously, if you're dealing with a patient that's already hypotensive, this is an adverse effect we're certainly looking to avoid. We also know that cardiac stunning occurs, as I mentioned. Typical scenario is left ventricular wall motion abnormalities that would certainly mimic the appearance of a myocardial infarction if you did cardiac ultrasound, which has been done, and that those changes persist for several hours after the dialysis session is completed, and they're typically asymptomatic. Patients would have no symptoms of chest pain, shortness of breath, or things of that nature, but they would simply develop new onset LV wall motion abnormality, which would later resolve. Unclear the reason for that. Other things can also happen as the blood concentration changes of solutes. We set up a concentration gradient, and this can cause water to move from different compartments in the body, leading to basically osmosis. And this can cause hypotension or other unwanted effects as well. We'll take an example of that here shortly and just show you kind of a cartoon of that concept. Dialysis patients also can have very impaired sympathetic response systems, so that when baroreceptors would typically um, cause peripheral vasoconstriction in the setting of volume depletion, uh, dialysis patients will get paradoxical responses here and actually vasodilate down there. And so rapid fluid removal for certain patients is very challenging because of the inability to increase their total peripheral resistance. All right, and let's just go to that kind of example of this fluid shifts. There's a lot of kind of hand waving around this term fluid shifts. People say, what happened? I said, well, we think it was fluid shift. So what are we talking about in that situation? So let's take a typical scenario for a dialysis patient where the solute load, whether that's sodium, urea, all the uremic toxins, and there are many, many, many toxins in addition to urea, which are probably pathologic, whereas urea is probably not that pathologic and not a major contributor to the so-called uremic syndrome. It just happens to be a molecule that's very easy and customary to measure. But these toxins are at high concentration in all of your classic three compartment fluid compartment models. We have our intravascular space, we have our interstitial space, and the bulk of the fluid, though it's not shown proportional here, really is in the intracellular space. 2/3 of the fluid volume of the body is here. 1/3 is shared between these two spaces. So we know that during the dialysis session, we preferentially are going to have access to this vascular and interstitial space because these two spaces communicate freely. Solutes move between the interstitial and vascular space. So as we change concentrations in the vascular space, um, fluid shifts, everything will be cleaned equally in the interstitial space, basically simultaneously with the vascular space down there. But we don't have access to fluids that are in the cell water. And so we'll see how that can have an impact. So as we begin the dialysis session, not only are we doing cleaning, but we're doing fluid removal, as we showed in that first diagram of convective clearance or ultrafiltration. So this ultrafiltration will basically effectively remove water for the patient, and that fluid is thrown out. The drain line in your typical dialysis machine will go to the toilet or to the sink in the ICU rooms, and that's very typical. As we're removing fluid, though, we're changing solute concentrations. And that's going to engender fluid movement. So let's look at what happens here. Here, we're pulling water from this space directly. We have our catheter in the right atrium, or we are removing fluid from the fistula. So we're removing this filtrate of blood. So this is the space we're directly removing water from. We're removing basically plasma water. And then the interstitial space is refilling that vascular space. And that's the process. Once we get into our dialysis session, 1.5 to 2 hours in, we've had significant cleaning of the vascular and interstitial fluid compartments, and the solute concentration's gone way down. In this scenario, we're still taking ultrafiltration off. We're removing fluid typically throughout the entire process. But now, as you can see, we have a situation where perhaps the urea here and the plasma water space is 100, and we've lowered it over here to 30. In this situation, not only are we removing water directly from the vascular space, but we've now set up a concentration gradient so that water, instead of moving from this space only to ultrafiltration, which we've determined how much fluid we want per hour. Now we have a scenario where fluid is moving back into the cells. This is osmosis. Water moves from an area of low solute concentration to an area of high solute concentration. So now you have water exiting the vascular space and interstitial space into the cells, and you have water exiting directly from the vascular space via ultrafiltration. And this is a setup for hypotension. And again, just kind of alluding to what we talked about earlier, left ventricular wall motion and left ventricular systolic dysfunction has been, categorized, is demonstrated multiple times, and this is just a sample example of a study that demonstrated that. Interestingly, the effect was independent of the blood volume removed, and what that tells you is that some of this is the physical effects of the hemodialysis procedure itself, and many of us suspect that it is the rapid changes in solutes and fluid shifts between compartments. So this suggests that it might be worth considering other methods which slowly remove solute in the setting of a fragile patient who's hemodynamically unstable. So before we jump into those things, it's probably worth reviewing this number of terminologies that's out there to refer to modalities that are dialysis or dialysis-like, or at least what we call kind of extracorporeal therapies, taking blood out and processing it. And so the classic is hemodialysis, also called intermittent hemodialysis or IHD. There is a gentler version of this with lower blood flow rates, lower dialysate rates, which does cleaning over a longer period of time with gentler settings, and that's called slow, low efficiency dialysis. This is also referred to as PERT, prolonged intermittent renal replacement therapy. The settings can be slightly different than SLED, but basically the same concept. Scuff, which you may hear more frequently in settings of heart failure and CCU type admissions where this has gained some interest, is slow continuous ultrafiltration. And this is basically that convective clearance idea where we're basically just removing plasma water, most removing a little bit more solutes due to the difference in pressure, but generally very little in terms of cleaning of the blood, mostly just removing fluid from those patients. And there are times when a patient may have a near normal creatinine, but the volume overload is so excessive that they can require a therapy like this scuff, which is kind of like SLED without much blood cleaning. CRRT is probably something you're more familiar with than just as familiar as hemodialysis. And we'll talk about those three subtypes. Lastly, peritoneal dialysis, which we won't talk about in this session, is very gentle fluid and volume removal and really was the standard of care for hemodynamically unstable patients and is still the preferred therapy in pediatric patients. So if you go to the pediatric intensive care unit, patients requiring dialysis will often obtain peritoneal dialysis, and that's very well tolerated. So let's talk about that hybrid therapy, SLED/PERT. It typically uses a traditional dialysis machine. This is a little bit an older picture, different than what we use, but all the elements here are here. Blood pump here, dialysate lines, a cartridge would be set up here. But this is kind of a fairly typical machine that you would see. Tablo machines are a little bit different down there, but they also will be employed if we need them in the inpatient setting as kind of SLED/PERT machines. The typical run can be anywhere from 8 to 10 hours, and truthfully, you could expand that to 6 to 12 hours. When you run dialysis this long, blood will typically clot the filters as it's going through the dialysis cartridges, which we saw the outline of on that New England Journal of Medicine kind of cartoon we looked at earlier. So you usually need some sort of anticoagulation scheme for this. And so some modalities can be run without anticoagulation. Because it's extended, this one often requires it. Depending on where you're at, this is run by the ICU nurse or the renal nurse. The problem is typical that there's a shortage of renal nurses, and tying one up for 8 to 12 hours can be very challenging. So the preference at most institutions is this is run by the ICU nurses. So moving on to truly continuous therapies, meaning that we're running these for the majority of the day, 18 to 24 hours. This is some terminology to get familiar with: veno-venous hemofiltration, CVVHF, which is basically the method of removing fluid via ultrafiltration and then taking a replacement fluid, which is basically IV fluids, but a balanced IV fluid solution, very similar to lactated ringers, and replacing the water that you removed, which is, quote unquote, dirty, with clean IV fluids. And that's basically it. If you do that enough times over a long enough period of time, you'll replace most of the, dirty plasma water with clean IV fluids, and all the good stuff will still be in there. No change in the red cell count. In veno-venous hemodialysis, you're using basically really slow hemodialysis. It's the same concept of using dialysate and using concentration gradients and clearing solutes that way. And then there's combining the two of them together. If one is okay, the other has some strengths. Maybe if we do them both together, we'll get better outcomes. And this is a very popular modality in Europe and is gaining popularity in the United States. And some small studies suggest that it may have some performance improvements in terms of outcomes, but more to come on that story. So starting with the most commonly used one at UVA, and that's CVVHF. And this again, just a definition of kind of convection and ultrafiltration. You apply a negative pressure. Some machines do, others would put a positive pressure in the blood component of the cartridge of the filter. And that basically causes a filtrate of plasma water to be removed, and it does drag some solutes with it. That's convective clearance down there. You'll often hear the term running even. If you go to the ICU, you ask the ICU nurse, how much fluid are you taking off this patient? Well, we're running even. And that generally means that the total amount of fluid going into that patient being administered over the course of an hour is being removed by, again, that process of ultrafiltration. So a patient may be receiving 200 milliliters in total of IV fluids, drips, et cetera, et cetera, et cetera. And the nurse sums all of that for an hour that's anticipated to go in and sets the machine to remove that equal amount of fluid. If they then select to remove more than the 200 amount of fluid that's being given, then the patient's running negative. Now, as we said, a volume of replacement fluid, which is basically very similar to IV fluids, is added either before or after the filter, and that replaces the water that's removed from ultrafiltration with this clean solution. For us, this is typically run without anticoagulation, but in our situation for COVID patients, we generally will run with anticoagulation with heparin, and we'll talk about that when we get to some practical points about COVID patients. So here's just kind of a cartoon. We have a filter. Remember, in hemofiltration or ultrafiltration with convective clearance, we don't have dialysate. We're not doing diffusion or movement down concentration gradients. What we're doing is taking blood, we're coursing it through the filter. Our next step then, and this is kind of the classical model, is we'll pull off some amount of water. We'll pull off some fraction of that. So if the blood flow is coming in at 300 mLs per minute, we might remove 50 cc's of plasma water out of here. We will then replace that equivalent amount of 30 to 50 cc's we removed with replacement fluid. And that replacement fluid at UVA is a substance, as a fluid bag called Prismasol. It comes in 5-liter bags. And you'll see this hung on the CRRT machine, several of the bags simultaneously. And they will be replacing this plasma water that we pull off, which is going out to a drain. Now, by pulling off fluid and then diluting it, we have reduced the concentration of urea. So the blood is returning to the body with a lower concentration. And so this blood will return and dilute the total body urea. Again, each cycle of blood flowing through the filter will dilute until eventually you'll typically be in equilibrium where you're removing urea at the rate that it's being replaced. And you can see basically near normal BUNs and creatinines in these patients after a few days. So that's CVVHF, and that'll be the most common one. CVVHD is basically slow dialysis. As we said, there's no replacement fluids down here. You're not replacing things. You may choose to remove fluid for patients that are volume overloaded, but that's not the goal, to remove fluid and then dirty blood and then replace it with clean IV fluids. The name of the game here is just to simply do the same thing we typically do in hemodialysis, but to do it in a slow enough way that we don't develop fluid shifts that would lead to hypotension or hemodynamic instability. Usually we use anticoagulation for this, but our preference is to use what's called regional anticoagulation, and that means that we anticoagulate the circuit, and that's the kind of the blood tubing and the filter, but the patient does not receive any systemic anticoagulation and doesn't have any effect from our anticoagulation, which effectively stays local in the machine. All right, and so in this example, we would still have that same patient with starting the therapy with a urea concentration of 100, but now we have kind of a two compartment where we have blood and we're going to have dialysate. In this situation, we'll pick a sample blood flow rate of about 250. This is generally a little high. Nowadays, we're using CVVHD with numbers of anywhere from 100 to 150, but for our purposes, this is fine. Dialysate will be here, and remember, they'll flow in a counter current way so that the dialysate will start with very low concentrations or no concentration of urea, and then it'll accumulate urea during the procedure. So in this situation, the dialysate flow is coming in very slow compared to a regular hemodialysis session. A typical hemodialysis session runs 600 mLs per minute. In CRRT, in this modality, we're running dialysate at 40 to 50 mLs per minute. So, greater than an order of magnitude less than a typical hemodialysis session. And that's really going to reduce your risk of rapid fluid shifts down here. So the dialysate will accumulate urea, and this will go and be our effluent. And the urea that was basically went down its concentration gradient, accumulated in the dialysate is gone, and that leaves the blood light of urea, and so it is effectively cleared a certain amount of urea from the blood space, which will go back to the body. And again, same thing, this process is repeated every minute for 24 hours a day times 2 or 3 days, and you'll see basically normalization of the renal function tests. Just a couple of things to think of, put this in the context of a larger one here. A couple of points here is in typical dialysis here, by convention, we have something called an arterial line and a venous line. This stems from the 1940s when systemic blood pressure was actually used. Surgeons would do a cut down line, place a catheter in the femoral artery and another catheter in the femoral vein, and so the patient's own blood pressure would pump the blood up to the cartridge and and provide the pressure in the machine. In modern days, obviously, as you know, we have a single dialysis catheter. That's a right IJ. It's a double lumen catheter, but the catheter, the red port, or it may look brown depending on which catheter you're using, is called the arterial port by convention because of that, but it's in the right atrium. And so that will remove blood that will come through the cartridge, and it will be returned through what's called the venous port down here too as well. As we said before, you can deliver the replacement fluid in CVVHF in hemofiltration either before the blood enters the cartridge or after, and there's some advantages and disadvantages to those methods, but for our purposes, just know that replacement fluid is used under CVVHF, and this is the typical catheter terminology of the arterial and the venous port. If you were to do CVVHD, you would be adding dialysate and combining both of these methods together for CVVHDF. So that's what we'll talk about next. So typically we have mostly CVVHF, and we add some additional clearance by classic diffusive clearance. So we just do a slow dialysis along with kind of typical CVVHF settings. Again, as we talked about earlier, very common in Europe. The machines that we have historically carried at UVA are not able to perform this modality, but the new Prismax machines are able to do that. We'll talk about that in a second. Just a cartoon combining what we said already. Again, the urea concentration would come in. It ends up getting cleared by both replacement fluid. We remove some plasma water. We replace some clean IV fluids, something very similar to lactated ringers. That dilutes the blood down fine. Dialysate then will also remove that. And so some folks think you can get a better clearance overall with this methodology. So moving to some of the technical considerations with CRRT in general, usually a catheter is required. An AV fistular graft, if a patient is hemodynamically unstable, can have difficulty sustaining the amount of blood flow. But mostly it's because the patient's going to be on this therapy for many, 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 many hours at a time. And it's extremely difficult to get a patient to, keep their arm in one single position. It's probably not a good idea, as the needles that are placed in a fistula or graft for a patient can move about and cause infiltrations and bleeding, and difficulties and problems with the therapy if the patient moves. And so a catheter is usually required for CRRT. Anticoagulation can happen in a number of ways. CVVHF will use heparin by preference, and we'll talk a little bit more about that in a minute. But that's generally the solution, and it has to do with the calcium concentrations and the way we do regional anticoagulation with citrate. And we'll talk about the details of that in a second, because that's important to know the complications. CVVHD can be run without anticoagulation, but here we generally use citrate anticoagulation. And we'll talk about how that affects calcium numbers. It can be a challenge sometimes for the nurses to keep up on the changes, and I'll show you why that happens in a moment. After we talk about the machines we have here, just to familiarize yourself, this is the next stage machine. You'd see bags hung up here on the hooks, and the cartridge for the machine and blood lines coming in would be here. And then there's a whole kit that comes ready, and it's plugged right in here at this point. And it's on these kind of casters down here. And this is the machine, CRT machine, that we have the most. This is the most commonly used in the MICU floors. We do have a couple of Gambro Prismaflex machines that are purposely purchased for cases that require ECMO for CT surgery in the pediatric population. And then we recently acquired the Prismax machines, which are the step up from the Prismaflex machines. And these are able to perform CVV, HDF, and have a number of other technology improvements over the former Prismaflex platform. But they do allow to do CVV, HDF. And again, you may see this on medicine patients if the volumes kind of consume all of our next stage machines, of which we have about 10 or 11 of those. We only have about 4 of these Prismax machines, but all do very similar things, except the Prismax can run CVV HDF. So I want to go back to regional anticoagulation, because if you do see CVV HD, or just slow hemodialysis, and regional anticoagulation, there's some characteristic electrolyte problems that can come with this. So how does this work? Trisodium citrate, we talked about that arterial line, which is kind of the dirty blood coming from the patient going to the machine. Before the blood goes into the filter, there's an infusion of trisodium citrate. Now, this trisodium citrate will ionize, and the free citrate will bind, effectively chelating the calcium, and this will create a new compound, this calcium citrate. Now, the ionized calcium is required for the clotting cascade. So by sequestering calcium and binding it to citrate, we have effectively removed or blocked one step of the clotting cascade. And so by doing this in this way, we haven't had to administer heparin or any other drugs, and certainly nothing needs to be systemic. Now, this combined calcium citrate is generally dialyzed out, but some of it may go ahead and pass on into the patient, and that may cause the serum calcium to rise, and what you'll see is a high serum calcium, but the ionized will still be normal. Now, as the calcium is chelated and becomes calcium citrate, and ionized calcium drops to undetectable, we would not want to return undetectably low hypocalcemic blood to the patient, where we could precipitate any number of adverse events. And so before the blood returns to the patient, calcium is replenished by way of a drip. And this is just a quick cartoon to show you how that works. What we already said is, in dialysis, blood comes in dirty, dialysate comes in clean, urea is absorbed into the dialysate as it moves down its concentration gradient. But in this situation, in order to keep blood from clotting on the paper filters down here, this citrate is added pre-filter. As the citrate infuses into the blood, again, you ionize the sodium and the citrate, and the free citrate now binds free calcium in the blood, creating calcium citrate. As this calcium citrate accumulates in high concentration, any substance in high concentration in the blood will go down its concentration gradient into the dialysate. And so we're able to dialyze out the calcium citrate. Now, this effectively means as the blood exits the cartridge or the filter, the calcium is zero. And so, in order to fix that problem, you need calcium infusion on the back end before the blood's returned to the patient. So, you have a system of local anticoagulation by infusing citrate and chelating calcium. The blood is anticoagulated, and before the blood returns to the patient, calcium is returned. And so, this is what we call local regional citrate anticoagulation, and it's very effective. This is the most important thing, the ionized calcium. Okay, a couple of complications to watch out for, vascular access complications. So you can get a cracked catheter. Catheters can migrate. Air embolisms are extraordinarily rare and generally have to do with negative intrathoracic pressure and a disconnect of the line. All CRRT machines have air alarms and can very effectively trap air, but a cracked catheter is really something that's out of the control of the machine. If air comes into the machine, through the arterial port, there's the machine can trap the air and will automatically shut down. If air enters just like any central line at the catheter itself, there's nothing the machine can do about that. But again, this would be an extraordinarily rare event. Metabolic angiogens, however, are not rare at all and can take many forms. We could see hypocalcemia. We'll come back to that again with the citrate. If the citrate anticoagulation is in use and the serum calcium is low, then and enough calcium replacement fluid is not being run, then a patient can get hypocalcemia quite quickly. This is generally well tolerated, and most of the time the protocol runs very well. But if you were taking care of COVID patients who are receiving azithromycin, hydroxychloroquine, or any kind of QT prolonging medications, this could be a problem. Hypernatremia can occur, particularly from the high concentration trisodium citrate infusion, which is basically hypertonic. And so you can develop hypernatremia from that. Metabolic alkalosis can occur usually as an effect of citrate toxicity, which in the current utilization of that term basically means a lot of citrate is not being dialyzed out effectively and it's getting into the body, and that citrate is being converted into bicarbonate at a 1-to-3 ratio. So one citrate will produce 3 bicarbonate molecules, and so you can develop a pretty significant metabolic alkalosis. Because of the long and effective dialysis, phosphorus levels can drop quickly and need to be monitored every 6 hours. We'll talk about that. And hypophosphatemia, as you know, can cause muscle paralysis, diaphragmatic paralysis when it's prolonged. And so evidence is as a prolonged vent wean, and then also rhabdomyolysis. Hypokalemia, if you're using a low potassium dialysis method, you don't adjust your bath after you've corrected the original hyperkalemia to normokalemia. If you continue to leave them on a low potassium dialysate strategy, then you will drop potassium quickly. Things that we talk about in CRRT, because we're aware that these can be problems, is that the labs are drawn every 6 hours in the first 48 hours, and that allows us to make adjustments on the fly. If these labs are stable after 2-3 days, then the frequency of labs can be dropped to about every 12 hours. Phosphorus should be added, but it certainly is a question in a lab you want to have several times per day in any patients on CRRT because the dialysis machines of the modern era are pretty effective cleaners. Each unit, whether that's MICU, SICU, CCU, has their own individual protocols for citrate and ionized calcium monitoring, though we've attempted to standardize that and given all units a standard protocol. Some still do it their own way. And as we said, there's multiple air alarms and air trapping systems within the device. So how do we dose our dialysis? Should we dialyze all day, every day? More cleaning is better. This is an answer we don't know the answer to. Or question we don't know the answer to. So how do we kind of say what minimally reasonable dialysis is? This is the dialysis dose, quote, that which all uremic complications are controlled, electrolyte and acid base balance is maintained, volume is maintained to the point the patient has a normal blood pressure with little, if any, medication. And that's an outpatient definition of how much dialysis. And so, in order to answer these questions, the VA ATN trial was performed down here, and that was mostly out of Pittsburgh. There was a question from a prior um, trial that suggested high doses of replacement fluid or hemodialysis fluid in the setting of CRT could improve outcomes. And what this showed is that's really not true, at least in this trial, that those that received higher doses of dialysis really didn't have any improved outcome versus those that received kind of a standard CRT dose of 20 to 25 milliliters per kg per hour of replacement fluid solution, for example. And so, that is a good news for us because these dialysis fluid bags may be in short supply during a COVID surge, and so we're generally not compelled to do more intensive CRRT except for some very specific indications like hyperkalemia that needs quick corrections. So, when would you choose one modality over the other? Well, first of all, obviously the patient should meet criteria for dialysis, and that O for volume overload is more and more being found to be important. And so we're starting dialysis often a little bit earlier than we might just for the labs in order to manage volume overload and hopefully wean patients from ventilators sooner. Um, in terms of official recommendations, our standard setting group would say evidence of hemodynamic instability. The truth of the matter is patients that are on a stable dose suppressor can tolerate hemodialysis with some amended settings pretty well, and one can run a CRT pretty intense to almost mimic hemodialysis. So really there is a fair amount of overlap, but generally at UVA, pressor-dependent patients will require CRRT. That's usually what we do. When do we convert people back from CRT to typical intermittent hemodialysis? Well, we generally like to see patients come off pressors for at least 24 hours. That's part one of a two-part assessment. And the second one is how much fluid are they getting in per day? Even though CRT is a slower fluid removal per hour, the fact that it runs most of the day allows you to remove more fluid over time. There are some intoxications which may suggest that CRT is the optimal therapy. We do employ CRRT even in stable patients in the settings of massive strokes with midline shifts because the rapid fluid shifts induced by changes in solute concentration could worsen or exacerbate elevated intracranial pressure. And so for massive strokes, we'll generally move to CRRT for several days until cerebral edema subsides. One of the things that's talked about in residency and fellowship is that CRT can mask a fever, and so a patient on CRT we may not know if they're becoming septic because we can't note their fever. And there is a blood warmer on the machine, and there's a set temperature for that, so that blood that circulates outside the body and cools doesn't return to the patient's body and induce hypothermia. But the machines generally will not mask the ability to detect a fever if it's significant enough. So that's really not true. When we talk about CRT clearance, what kind of if you're trying to figure out how to dose your antibiotics, we call that is the quick and dirty is it's roughly equivalent to the effluent rate per minute, but CRT generally delivers clearances in the 20 to 30 mils per minute range, or kind of stage 4 CKD basically type range there. And if you're not sure how to calculate this because you're trying to figure out what clearance to use for drugs, talk to the nephrologist. There are various CRRT dosing schemes for antibiotics, and that's pretty important because high dose CRRT can remove antibiotics very quickly. And if the pharmacist that's assisting with medication dosing isn't aware the patient's on CRT, they may be dosing by GFR, they may be dosing for someone on IHT. So it's good to ask specifically for CRT dosing. Just a few things which most of us have probably encountered already in our practice is that patients whose hyperkalemia or acidosis is so refractory that even intensive CRT can't change it. Generally, those are pretty poor prognostic scenarios. You may buy some time for patients such as this by bringing in a hemodialysis machine and improving the potassium and then putting them back on CRT. But generally speaking, patients that break through CRT have poor outcomes. Now, the question that comes up frequently is how much fluid can be removed per hour and over a whole day with CRRT. And the answer to that is generally we advise, no more than 300, certainly, and most of us would say no more than 200 mLs of fluid is removed per hour. And so this limits the amount of fluid you can remove from the body to, depending on how much you're taking off, to 4.8 to 6 liters per day. Now that is running all day long. So again, slower in terms of fluid removal per hour, but more fluid removed overall through the course of renal replacement therapy. One thing that's also out there is people ask for CRT in the setting of poor perfusion or other types of lactic acidosis. And CRT does not have the ability to clear lactic acid in a meaningful way. The clearance of it's something like 3%. And so, correcting the underlying problem is the answer to lactic acidosis. As we said, the adequate dose of CRT is basically been pinned down from that VA ATN trial. But if you continued to go higher with more and more and more dialysis, would patients have a better outcome? We don't know the answer to that. And no more modality, whether it's SLED, whether it's intermittent hemo or CRT, has been shown to improve mortality at all in any well-done studies. A couple of practical points about COVID and CRRT. So I wanted to go back to this. If COVID shares a lot of, an infection with COVID shares a lot of, commonalities with other infections of aggressive immune responses that we might see in septic shock or ARDS. The thought is that the increased or enhanced cytokine removal by using CVVHF or that process of ultrafiltration that might lead to superior outcomes in COVID. And so many in our field have recommended that we start with CVVHF. That same concept should play and hold true in sepsis as well. And when this was studied, however, this middle molecule process removal didn't seem to improve outcomes at all. And one theory for that is that just as there are pro-inflammatory cytokines, there are anti-inflammatory cytokines, and the dialysis machine is not smart enough to take out only the bad actors. And so it probably doesn't make a difference, frankly, which one you use. But, based on this concept of middle molecule clearance, UVA, along with most other institutions, will be employing CVVHF as our modality of choice. In order to keep circuit clotting at bay, what we have heard from other institutions that have a high volume of these patients is that there is a lot of clotting, potentially due to the inflammatory state, but the reason that's unclear. And so traditional CRRT with no anticoagulation is really not feasible in these patients. And they require pretty significant boluses of heparin, basically every hour, around 500, keeps the circuits up for most of the day. And that was kind of a hard lesson we learned from some of the colleagues in New York. There have been cases where patients are refractory to heparin, and there are doses that people feel are somewhat risky, and or if the machine simply continues to clot and break down despite the best efforts of heparin, then others have advocated moving to argatroban. As we said, CVVHD at UVA is usually run with citrate. However, again, because you're chelating calcium, especially in the beginning of the CVVHD run process, while the nursing staff is trying to sort out the rate of calcium infusion to return the patient to normal, hypocalcemia can occur. And if this occurs with, again, all of these QT prolonging medications, that may predispose someone to a arrhythmia. What we just said. So because of these reasons, middle molecule clearance and the risk of hypocalcemia, CVVHF will probably be our default choice with high dose heparin. Okay, so running through, and I apologize for the couple of typos in this talk. Running back to our case, we have a 65-year-old with AKI. Though there's some urine output, she remains hypoxic. She's received volume resuscitation. However, the patient's intubated on a high oxygen flow, receiving many drips, and is unable to remove enough fluid on her own to make up for all the fluid coming in from the drips. And so in this scenario where a patient's hypoxia is worsening, number one, from their primary disease, but then secondly, from fluid overload administered, dialysis is reasonable, even if it's not for hyperkalemia or uremia. So CRT would be chosen in this patient who's hemodynamically unstable. In this case, we would choose CVVHF as our default choice, and you would see a dose of 25 mLs per kg per hour of the fluid. In this case, we would use Prismosol. And so what you would see would be an order for a bag of 5 liters of Prismosol to be delivered at this rate of 1,750 mLs per hour. In addition, you'll see the protocol for high dose heparin as well. Typically on that next stage machine picture, you would see when you're looking at a next stage machine 4 5-liter bags hung, and this is very helpful for the nurses because they don't have to go back and forth and get additional bags when the first ones end. In the modified COVID protocol, instead of hanging the usual 4, we would hang only 2 because if the treatment is broken down or the order is discontinued, then all the bags taken out of the pharmacy would be thrown away. So we do want to keep these as dialysis fluids at a premium. So we'll hang only 2 bags on the machine in this case compared to the usual 4. So those are some of the practical points about COVID that I wanted to finish, and we'll just talk about, kind of finish up with summary points here. So renal replacement therapy relies on really 2 types of clearance. Traditional outpatient is usually diffusion, but on the inpatient ICU service, we're typically using that convection ultrafiltration, same thing. Fluid removal followed by a replacement of a clean replacement fluid or balanced solution down there. And this CVVHF modality will be the primary principal one we use. Intermittent hemodialysis use is limited by hypotension, and because it's a short session, even though it can remove a lot of fluid during that period, it generally does better with hemodynamically stable patients not receiving a lot of fluid. So a lot of fluids and low blood pressure typically equals CRRT. Lots of continuous modalities available: CVVHF, HD, and HDF, and as well as things like SLED and PERT, which are kind of in between modes. All of these are considered roughly equivalent. There's no better one in general, so we kind of pick the one that's most appropriate to that particular patient. Complications arise with CRT. The most common are electrolyte abnormalities, and when using citrate anticoagulation, metabolic alkalosis. Checking the labs frequently is important. Ensuring that you're getting phosphorus and checking that at least twice a day is very important, and you need to stay on top of the phosphorus repletion. It's very important. Modified COVID protocols from our usual CRT protocols will dictate the use of CVVHF and high-dose heparinization. So what else can go wrong? Intensivists should be monitoring electrolytes for signs of over-treatment by dialysis, and these would be things like an unusually low potassium and very low phosphorus levels. Again, there can be a number of bad consequences to hypophosphatemia if it is prolonged. Hypophosphatemia for a brief period of time, hours, days, shorter period is okay, but once one gets into many days of hypophosphatemia, rhabdomyolysis, and again, diaphragmatic affective paralysis can occur. And we talked about calcium derangements, high and low in CVVHD with regional citrate anticoagulation. So typically at the end of a presentation, we would take questions, but in this situation, we obviously can't do that, but feel free to shoot me an email, stop me on the wards if you have any questions. Obviously, nephrology will be following all patients that require renal replacement therapy and dosing it. Most important is certainly to watch out for those complications of CRRT. And if you have any questions or concerns, like I said, feel free to email me or just grab me on the wards here, as I'll be covering these folks along with you over the next few weeks. Thanks very much for your time and attention.